Welcome everyone to the CMENAS virtual fall colloquium, Public Health and Pandemics. We are very pleased that you have joined us today. Today our session is about obesity in school children and it's linked to chronic diseases, as well as weight and body image in the Middle East, perspectives from 2021. My name is Rima Hassone. I'm the Community Outreach Coordinator at the Center for Middle Eastern and North African Studies. This colloquium series, as well as many of our activities, are funded by a Department of Education, a US Department of Education Title VI grant. CMENAS, or the Center for Middle Eastern and North African Studies, is a national resource center. Thank you so much for joining us today. We have two guests today, Dr. Huda Hourani and Dr. Sarah Trainer. I'll first introduce Dr. Hourani. She will speak fast for about 20 to 30 minutes, as will Dr. Trainer, and then we will air questions out loud. Please do post your questions in the Q&A feature, and I will keep track of them, and I will share them with the two guest speakers after their presentations. I'm going to introduce first Dr. Huda Hourani. She is an associate professor in the Department of Clinical Nutrition and Dietetics at Hashma University in Jordan. She received her PhD in nutrition from Oxford Brookes University and has taught a variety of undergraduate and postgraduate nutrition and dietetics courses. In collaboration with the World Health Organization, the Food and Agriculture Organization, the United Nations Children's Fund, hospitals and colleges, she has taken part in a number of courses and training workshops. The World Health Organization has named her regional facilitator for the new World Health Organization Growth Standard. Obesity and its effects on people's lives have been the subject of several of her publications. Welcome, Dr. Hourani. We are so pleased that you have joined us and we're eager to hear from you today.
Thank you, Rima. Good evening, everybody. It's nice meeting you despite it's a virtual meeting, but it's nice to talk to you. Thank you, Muzammel. Thank you, Christine. Thank you, Sarah. And thank you, Rima, giving me this chance to be with you. Today, I'm going to talk about obesity and school children. So obesity among school children and its relation to chronic diseases. Mainly we are talking about obesity, about diabetes and hypertension, but mainly I will concentrate more on diabetes. So if we have an idea about what are the causes of obesity, if we look at increased use of processed and less nutrient-dense foods, also decreased intake of whole fruits and vegetables, increased consumption of sugar, high sugar foods, for sure. Consequently, globally increasing in the risk of being overweight or obese, along with producing epidemic chronic diseases at earlier ages, which is, I will give two examples, which are type 2 diabetes and hypertension. And type 2 diabetes in children, not type 2 diabetes among adults, because it's well known that type 2 usually appears among adults. So our concern now, our concern in this lecture, the school children. Now, if we go to definition of overweight and obesity, actually those two terms are not alike. the definition of overweight, it's not like obesity. Obesity is an excess of body fat or adipose tissue. It can be defined as proportion of body weight composed of adipose tissue, the percent of body fat that's greater than some standards. We have standards. We have standards for males and females. What's the normal fat percent in each body? Because of it's often impractical in the clinical setting to measure the percent of fat using body composition analysis. So it's defined by body mass index. So if body mass index more than 30 kilogram per meter squared for adults, so it means that the person is obese. For children, it's a different story. Obesity is defined in something called Z scores. So if the age, BMI-for-age at or above +2 Z square, it means that the child is obese. So how we can guess, or how we can point that this child is obese when we measure his body mass index? We want to point if he's above +2 or not. So we have something called BMI-for-age charts. We have two charts, one for boys and one for girls, and it covers 5 to 19 years for both sexes. And we have other growth charts or BMI charts for children birth to 5 years. But here our concern is the school children. So as you see, we have 7 lines, 3 below 0 and 2 above 0. The above 0 we have +1 and +2. If the child, his BMI-for-age above 1, it means that the child is overweight. And if her BMI-for-age above 2, it means that she is obese. And it's mentioned on the chart. The figures between below -1 and above -2, it means that the child is normal. And the next one is the same, but for boys. So also we point where the child is to define overweight or obesity. Now, here are some statistics from different countries in the Middle East. This paper published 2017, before COVID-19. And we have some figures. For example, we can see that some countries, the prevalence of overweight and obesity are high. It's more than 15% for both. Some countries, obesity is more than overweight. Some countries, overweight and obesity are around quarter of the children, the age group 2 to 19 years. So this is some statistics. Now, the issue that this obesity will cause many problems for children. The first one is the type 2 diabetes. Type 2 diabetes among children, among youth. How it's defined? Type 2 diabetes significantly increased in pediatric population, which is affected by obesity worldwide. So the main cause is obesity. The progression from normal glucose tolerance to type 2 diabetes involves intermediate stages of impaired glucose and impaired glucose tolerance, which is also known as pre-diabetes. So if you look at this chart, at this table helps to diagnose diabetes, whether they are children or adults, whether they are type 1 or type 2. Those are the cutoff points. For example, fasting blood glucose, if it's less than 100, it means that the child is normal. If his blood glucose between 100 to 125, it means that he has prediabetes. So that's what we were talking about. We were talking about prediabetes. So we have impaired fasting glucose, impaired glucose tolerance, which is the second one, OGTT, or oral glucose tolerance test. If the reading is 140 to less than 200, it means that the child has prediabetes. Or if hemoglobin A1C 5.7 to 6.4%, it means that it means that he has diabetes. So the pathophysiology of the underlying the development of this glucose metabolic alteration is multifactorial. We can't say that it's one factor. Obese children and adolescents affected by impaired glucose tolerance and type 2 diabetes, which is due to severe insulin resistance, which is associated with increased lipid accumulation in visceral compartments, liver, and muscle tissues. So our concern, it's the lipid accumulation. So how we start to do diagnosis for children who might have type 2 diabetes. Now, risk-based screening for prediabetes and or type 2 should be considered for children and adolescents after the onset of puberty, when they are 10 or more. For sure, we want to do this test when they are 10 to 12 years, whichever occurs earlier. So if we discover that the child is overweight or obese, okay, we should go further step to know if he has type 2 diabetes or not. So the risk-based screening for asymptomatic children and adolescents in a clinical settings. So as we said before, if the child is overweight or obese, we should look for the following factors. If he has one or more, in addition to obesity or overweight, if he has one or more additional risk factors, so this child should go and check the blood glucose. The first risk, maternal history of diabetes, type 1 diabetes, if the mother already she had diabetes, or she got gestational diabetes during the child's gestation. Family history of type 2 diabetes in first and the second relative degree relations. If his father, his brothers, his grandfather, so this is another risk. And the third risk, which is race and ethnicity. So this is another factor. And the last one is signs of insulin resistance or conditions associated with insulin resistance, such as hypertension, which we will come to it soon, and dyslipidemia, polycystic ovary syndrome, or small for gestational age birth weight. So those four factors. So suppose that the child is obese and has one factor. So this child should go and check blood glucose. If he has two factors, the risk will be more, and etc. So the other problem that we have, and it's prevalent among school children, which is hypertension. Now, this table showed how we do screening for blood pressure, okay, for children. Now, if you look at the table, we have the age and we have the systolic and diastolic blood pressure, and we have figures for boys and figures for girls. So from 1 year to 12 years, we have cutoff point. Those cutoff points mean that the children are normal. If his systolic blood pressure, for example, he's 10 years, if his systolic blood pressure is 108 and the diastolic blood pressure is 72, it means he's normal. Above that, we start to have other classification. If he has elevation in blood pressure, if he has stage 1 blood hypertension or stage 2 hypertension. And I want to concentrate that the cutoff point are not like for adults. If you look at children, 13 or more, the cutoff point like normal, 120 for systolic blood pressure and 80 for diastolic blood pressure. But for before 13 years, no, it's a different story. We have different cutoff points. So those are the cutoff points for the definition of blood pressure categories of stages. So we have for children 1 to 13 and more than 13. So the blood pressure is classified into 4 categories: the normal blood pressure, the elevated blood pressure, stage 1 hypertension, and stage 2 hypertension for both age groups, 1 to 13 and 13 or more. Now, this is the study I conducted 2020, screening for non-invasive risk factors of type 2 diabetes in overweight and obese school children. We want to see how many risk factors of the risk factors we mentioned, the 4 risk factors, are on those children. And as we said before, they are obese and overweight. So if we look at their characteristics, the mean body weight, height, waist to height ratio, body mass index, Z-score, systolic blood pressure, and diastolic blood pressure. Actually, we can't depend on weight alone and height alone. And for example, weight alone. So you can see that the mean weight is 46.9 for the boys group, and for the girls, 48.2. They are 871. We have the third character, which is waist to height ratio. Actually, we don't have cutoff points for waist circumference for this age group, so we use waist to height ratio. Waist to height ratio more than or equal 0.5, it means that this child is obese. And as we said, we have the systolic and diastolic blood pressure. Also, it's a mean and standard deviation. It means nothing unless we classify them if they have hypertension or stage 1, stage 2, or elevated blood pressure. Now, let's see how they are classified according to body mass index. Let's see those 871, how they are distributed. Severe thinness and thinness, which is below -1 and below -2, as we saw in the growth charts, actually we don't have that much. So the percentage is around 6% in the whole sample. The normal are 47. But if you look at overweight and obesity, overweight is 26%, around 1/4 of the sample that are obese, and 19%, the 1/4 are overweight, and 19 were obese, and it's a high percentage actually. And you can see the differences between overweight, the prevalence of overweight and obesity among boys and girls. So the figures are here, are there. Now we want to check those risk factors. We said that we have different risk factors: family history, maternal history of diabetes, and hypertension. So if we look at the presence or absence of those risk factors, the presence of family first or second relative degree with diabetes, the present 80% of the sample, they have a family history of first or second relative degrees. For the maternal history of diabetes or gestational diabetes, actually 17%, their mothers had diabetes. Blood pressure, it's classified into normal, pre-hypertension, or elevated, and we put stage 1 and stage 2 together under hypertension. They have the percentage of hypertensive children were 26.8, and this one, which is waist for height, actually it's not one of the risk factors that we were talking about, but it's an indicator of obesity. I think we should start look at it. As 27% of the sample, they have abnormal waist to height ratio. So this is a proof the prevalence of obesity among this group of students. Now, how many risk factors? We said that if the child has, he's obese or overweight and had one or more, so the child should go and check his blood glucose. So if we look that 12.6% of the sample, they don't have any risk factor. 54, they have one risk factor, and 29, they have two risk factors, and 4.3, they have three risk factors. So it means that those 54%, they should have, they should check their blood glucose. Now, they should check their blood glucose. Now, suppose that they don't have, the blood glucose says that he's not diabetic, or even he don't have pre-diabetes. So what shall we do? Actually, we should repeat that in 3 years. So the screening should be repeated in 3 years. But if the child continue gaining weight, no, we should reduce, not within 3 years. It should be less than that. So everything, it depends on the prevalence of obesity in this age group. And this is a chart, a figure. The children compared to the World Health Organization Child Growth Standard. Child Growth Standard is the green one, okay, which is a bell shape, normal distribution. The pink one is for girls, and the blue one, it's for boys. So as you see that the both boys and girls, they are moving to the right. What does it mean, moving to the right? They are moving from the normal distribution. Going to the right, it means we have a +1, +2, +1, +2. So it means that we have overweight and we have obesity. So if you look at the minuses, which is thinness and severe thinness, we can't see that among them. So this can show our children position.
Sorry, Professor Farani, I just wanted to give you the 5-minute alert.
Yeah, this is the last slide. Thank you, Rima. This one, actually, I want to share it with you. It's not in that paper, Okay. Actually, we did a study during COVID-19 lockdown period. So also among children 6 to 12 years, 13 to 17 years, we checked their, actually it's a reported weight, it's not, we didn't measure. So before lockdown and during lockdown, what happened? So if you look at overweight, it was 18.8 in the first group, it became 24.1, while for 13 to 17, it was 20.3, get down to 20.7. But for obesity, for the first group, 6 to 12 years, it's from 16.7 to 24.1, and the other group, 12.9 to 16.4, and actually it's a significant increase. So we should do something after what happened during lockdown and COVID-19 pandemic. Thank you very much for your attention.
Thank you. Thank you so much, Professor Horani. Thank you so much. And we'll hold questions. We will hold our questions till after the second presentation by Dr. Sarah Trainer. Dr. Sarah Trainer is a medical anthropologist. Her previous work has included ethnographic research in the United Arab Emirates, the US Southwest, and the US Southeast, and focuses on experiences around weight, body image, food, stigma, and health. Her recent book of 2021, Extreme Weight Loss, Life Before and After Bariatric Surgery, explores the ways in which experiences around health, stigma, and weight change for people who undergo weight loss surgery. She is currently the research and program coordinator for a National Science Foundation funded advanced program at Seattle University in the state of Washington. Thank you so much, Dr. Trainer, for joining us. We're so looking forward to your presentation.
Thank you so much for that introduction. Please do let me know if you can't hear me. But without further ado, I will dive in. Dr. Al-Horani said, good evening, and from Seattle, I say good morning, as it is only 11:30 a.m. here. I'm very pleased to be with you all. And the title of my talk, which Kristen is graciously running for me, is Weight and Body Image in the Middle East. And I did adapt the title slightly to a case study in the UAE. So Kristen, can we go to the next slide? So an overview of the talk. There are 4 basic points that I want to make during this talk. 1, obesity as a medicalized bodily state currently draws global attention as a problem that public health programs all over the world need to solve. 2, social scientists in recent years have argued that the sociocultural devaluation of bodies defined as fat, in other words, fat stigma, is also increasing in frequency worldwide. And I do want to make a small postscript comment here that in clinical settings, you see a very standardized use of obesity, but in everyday practice outside clinical settings, which is what I'm mostly focused on in this talk, you see very messy interchangeable uses of fat and obese. And so I will echo that in that messy everyday usage in this talk, and you'll see me using both terms. Returning to these main points. The third one is that what the points number 1 and points number 2 mean is that norms, sociocultural norms, valorizing not fat bodies appear to have spread at the same time that we see rising average body weights. So in this paper, I use ethnographic data from the UAE and also epi data from the region as a whole to examine this dual phenomenon. So moving to the next slide. So I know this is an interdisciplinary series. With that in mind, it's helpful to think about what medical anthropology is and what it does. Medical anthropologists, by and large, are interested in health, wellness, articulated ideas about these amongst people and communities. We're interested in the interactions that happen in clinical settings. And we're very interested in bodies. So the study of bodies has been central to the field of medical anthropology from its inception. Most medical anthropologists have focused on the ways in which bodies are situated in highly localized places, times, and contexts. You can't take a body out of where that body is, where that person is. And these contexts can be physical, sociocultural, and or political economic. So you are simultaneously inhabiting many different types of contexts. At the same time, most medical anthropologists working in 2021 also recognize that bodies are embedded in very large, highly influential international circuits of capital, labor, finance, communications, food, products, and so on. So they are both locally situated and also impacted profoundly by globalization. Next slide, please. So I want to start by thinking closely about obesity from a very classic public health perspective, as evidenced in the World Health Organization's documents on this subject. And I was very grateful to Dr. El-Harani, who, although she focused mostly on children, and I will be focusing more on adults, gave you sort of a preview and delved a bit into the BMI, as well as the BMI calculation. But I will go through some of this myself, just very briefly. So the first point I want to highlight from the WHO information on the subject is they echo Dr. El-Harani in saying overweight and obesity are defined as abnormal or excessive fat accumulation that presents a risk to health. A body mass index over 25 is considered overweight and over 30 is obese. The issue has grown to epidemic proportions, with over 4 million people dying each year as a result of being overweight or obese in 2017, according to the Global Burden of Disease. Moving on to the other point I would draw your attention to from this. They go on to say overweight and obesity are major risk factors for a number of chronic diseases. Again, in the previous talk, you heard about many of these. And the WHO cites cardiovascular disease, type 2 diabetes, joint-related issues, and many other chronic diseases. And then lastly, the part that I really want to highlight for all of you is in their third slice of information that I'm providing, they say many of the causes of overweight and obesity are preventable and reversible. However, no country has yet to reverse the growth of the epidemic. I can't stress that sentence enough. No country has yet to reverse the growth of this epidemic. Although other factors are involved, the fundamental cause of obesity is an imbalance of calories consumed and calories expended. As global diets have changed in recent decades, there has been an increase in the consumption of energy-dense foods high in fat and free sugars. There has also been a decrease in physical activity due to the changing nature of many types of work, more access to transportation, and increased urbanization. Lowering the risk of overweight and obesity includes reducing the number of calories consumed from fats and sugars, increasing the portion of daily intake of fruit, vegetables, legumes, whole grains, and nuts, and engaging in regular physical activity. So there are a few points I want to draw your attention to in all this information. The first is that overweight and obesity is a complex bodily state characterized by certain thresholds of weight and fat that are identified as excessive. However, the most common way of identifying overweight and obesity in adults worldwide is the BMI, and that is a practical, pragmatic measure to collect. It's easy to collect height and weights from adults. It has some problems in terms of accuracy. You can have adults who are perfectly healthy, who end up in an obese category based on their BMI, and you can have adults who are categorized as a normal weight who are not at all healthy. However, what this also shows, if we look globally and at the population level is that we have seen, as the WHO earmarks, dramatic increases over the last century, and in particular over the last half century, in rates of overweight and obesity at the population level. And this is due, as we also see from this, due to structural factors, major changes in food availability and the urban environment around many people and the demands of jobs and similar factors. As a result of this, we are not seeing decreases in overweight and obesity. Again, no country has yet to reverse the growth of this epidemic. And part of the reason for this is that much of the programming to date, especially sort of as it has percolated out from countries like the US, emphasizes individual behavioral change, which you also see in this information. So lowering the risk of overweight and obesity includes reducing the number of calories consumed. They do not mention structural change. So these are all points worth revisiting. Kristen, can we go on to the next slide? So another fact sheet from the WHO. I will only pull out a couple of points from this because I think Dr. Al-Harani covered much of this. The most important point to stress from here is that the worldwide prevalence of obesity nearly tripled between 1975 and 2016. That is such a significant change. The other point is that we see this massive increase in overweight and obesity in adolescents and children. All right, next slide, please. So still on the WHO website, here I think it's very interesting. So if you look under the category of non-communicable diseases, you find that they have global maps showing rates of type 2 diabetes and other diseases, but they also have rates of overweight, rates of obesity, and they show the prevalence of different BMIs across different countries in the world. And that's very interesting because there is a continued debate in many medical and public health programs whether obesity should be considered an independent disease or not. Most entities in the US, for example, most medical entities, it is categorized as a disease by itself. Overweight is not true of this in this respect. So it's interesting these are all categorized in here because of their associated risk factors. The other thing to draw your attention to from this very superficial gloss is where we see the highest rates of obesity, overweight, and BMI. Definitely, one, it is a global problem, as we saw from the WHO. And two, it's certainly clustering in some parts of the world. Kristen, can we move on? So to recap, what is obesity? What causes obesity? What does obesity do? And where do we find it? So obesity is, again, a bodily state that is most commonly identified using BMI markers at the population level, but has more complex markers associated with it at the individual level. It is at the structural level caused by these massive sea changes in patterns of daily life that we see accelerating in the decades after World War II. But at the individual level, it is very simply calories in, calories out, and imbalance. And it's very interesting seeing which variable draws more attention. What does obesity do? Well, obesity is associated with many chronic diseases and increases in these, especially at the population level. But as I'm going to talk about more in this talk, it also is associated with particular types of stigma, which then create all sorts of very specific life experiences. And finally, where do we find it? Well, we find it globally, but we find it increasingly in certain countries and in certain socioeconomic groups. Kristen, next slide, please. So thinking about obesity in the Middle East. So very similar to the larger snapshot of what the WHO showed going on globally. Obesity, overweight, and BMIs have all increased in the Middle East in recent decades. Chronic disease rates have also increased. And these are fundamentally rooted in the observation I made earlier that activity and consumption patterns have altered. We see increased sedentary living, increased consumption of high fat, high sugar, high salt, pre-made convenience foods. Much of this has been theorized as part of this nutrition transition where we see rather than not enough calories being available, we see a lot of cheaply made convenience, high energy calories being available in societies worldwide. We also, the concept of a health transition was very popular about 20 years ago and still continues to be used. This idea that we see a shift where the global burden of disease shifts from acute diseases, infectious diseases to chronic diseases, that has been complicated conceptually and practically by the increase in, first we saw this rise in drug-resistant infectious diseases, and then more recently we've seen the effects of COVID. But it's also still an interesting concept to think about. So Kristen, next slide, please. So looking in more detail at this global map of obesity, and it's parsed out between males and females. So if we look at this map, a country like the United States, where I sit today, has very high rates of obesity for men and for women. When we look at North Africa and the Middle East, we see that there are very high rates of obesity for women and moderately high rates of obesity for men. This difference is usually ascribed to, I hear the two most common explanations I hear are one, women tend to be slightly more sedentary in the Middle East, and two, the lingering impacts of more positive connotations of larger female bodies. Kristen, next slide, please. So with that in mind, let's consider the second part of this problem I'm talking about today, which is fat stigma. So very similar questions to what I asked with respect to obesity. What is fat stigma? What causes fat stigma? What does fat stigma do? And where do we find it? Next slide. So as a medical anthropologist, I became interested in fat stigma, not because of something I read, but because when I was doing research in the UAE, it was everywhere. And so I went off and I did research in order to understand what was going on. In the 10 years since then, I have spent much of my career thinking about the impacts of fat stigma. And I have looked at it cross-culturally across many different sites. So what is stigma? Well, stigma was a lot of the early theories on stigma were done by a man named Irving Goffman, who was looking at what he called abominations of the body, how certain traits or conditions in particular sociocultural contexts are stigmatized. Goffman was more interested in mental health, but his theories are very applicable when transposed to other traits and conditions. And there has been a huge amount of research done on fat stigma in recent years. So the departure points for a lot of this research are a few points, some of which I mentioned earlier. First, we see norms valorizing not fat bodies have spread around the world at the same time that average body weights have risen globally. So I said that earlier. What does that mean? It means that if you look 50 years ago, you see all sorts of different sociocultural ideas about what is a beautiful body, what is a good body, what is a healthy body. And many of those ideas were very rooted in an idea of a body that was a relatively higher weight. This has dramatically changed over the course of the last 50 years. We see increasingly numbers of diverse sociocultural settings that echo normative ideas that in order to be a beautiful body, in order to be a healthy body, you have to be thin, or at least you have to not be fat. And casual everyday definitions of what is fat have also narrowed, literally and figuratively speaking. And of course, at the same time, we see that average body weights have risen globally. So we see this profound deepening aesthetic rupture overlaying a profound cultural rupture underneath that. At the same time, and this is the part that I have found most interesting in my own work, we see ideas of individual responsibility around weight percolating worldwide as well. And I think the most interesting early research on this was done by a woman named Ann Becker, and she worked in Fiji, and she looked at what happened. She started writing in the 90s about watching not just a formerly quote unquote fat positive society in response to transnational media and social media exposure. You see this trend towards valuing thinner bodies. So that's the first half. But she also noted that in earlier understandings of health and beauty, responsibility for someone's body was at the family level. So if you saw someone who didn't seem healthy or seemed to be having trouble, you assumed something was awry in the community and the family, and that the thing that needed to be fixed was at the family or the community level. And what we see happening over time is that increasingly the emphasis, especially in adults, is that the individual is responsible for their weight. The individual is responsible for their health. And this is really embedded in a lot of medical and public health efforts worldwide, as well as in a lot of popular discourse around bodies. And this has profoundly changed the way many people understand weight, health, wellness, illness, and disease. So when we think about fat stigma, it's not just that we've seen preferences for thinness starting to proliferate, but also that at the same time, we see this globalizing belief that thinness is the result of individual management of self and individual hard work. So what this means is that bodies are read in this paradigm. Bodies that are identified as fat and obese are not just aesthetically displeasing, but they also signal something that is awry with the person. But something that is awry emotionally and socially as well. And that is what creates stigma. And what I have found so interesting in my research projects is that you can talk to people in places as diverse as Osaka, Japan, North Georgia, USA, Encarnacion, Paraguay, and they will tell you, they will articulate very clear recognition that yes, obesity and fat and weight in general has gone up in our community. So have associated chronic diseases. These are a result, and then they name all the things that I've gone through. There's less healthy food available. The healthy food that's available is more expensive. The jobs most people have are not conducive to being active on a daily basis. Exercise opportunities are frequently expensive. They will articulate all these larger structural problems, but then when you ask them about themselves and their daily practice or their family members or friends, they will say, well, but none of this matters. It's really up to me. And so you see this recognition that there are all these larger structural matters that are impacting people's weight and management of weight, sitting side by side with this idea that it's still up to the individual to manage. Kristen, next slide, please. So let's think about the UAE. So the UAE in 2021 is sitting on a couple of decades of rapid development. And with that development has come just profound change at all levels of life. So I give you a snapshot of the major arterial road that runs through parts of the UAE with the metro transposed over it, and also a snippet of one of the headlines, some of the headlines from one of the local papers. And one observation I want to make here is that my research in the UAE predates the COVID-19 pandemic. And I think that's really important to keep in mind as I proceed, because many things are similar. Now, for example, a lot of this resonates with much of what I found while I was living in country in terms of emphasis on women's health, healthcare infrastructure building, but urban infrastructure building. But if you look at this local paper's health section, immediately what stood out to me was how much of this is focused on COVID-19, which very much echoes the health sections of my local newspaper here in Seattle. So this is an important distinction because I recognize that COVID-19 has upended the way health is being approached and thought about in country, and that's still very much being parsed out. Kristen, next slide. Okay, so as we saw from that larger map I showed earlier, and then from this slightly more detailed snapshot of obesity in the UAE, obesity and overweight are high in country. They're not only high in country, but they are very much have been identified by public health and by the government as an issue that is a problem for the country that needs to be intervened upon. And this messaging has been going on for a good 20 years at this point. Next slide, please. So it is in this context that I did my research. So my research, I started with two larger observations. The first is that we see very high rates of obesity in country, as I just said, including among Emiratis. And that's an important qualifier because the population of Emiratis in country is small compared to the expat population. And again, the observation that rapid concentrated development has occurred across the Emirates in an incredibly short period of time, especially in the Emirates of Dubai, Sharjah, and Abu Dhabi. So we have seen this rapid change in social, cultural, economic, political, and environmental fabric of the country, especially in the urban centers. So with 5 minutes?
I just wanted you to know it's the 5 minutes.
I think I'll be about 10, maybe slightly less. Okay.
That sounds, thanks for the information.
Thank you. So these were my starting bedrock, this was my framing as I went into the project. What I immediately found in my ethnographic in-depth study with a bunch of young university women students at a couple of universities situated in different parts of the Emirates. First thing was high rates of awareness about the quote unquote obesity in country. They had all heard the messaging from various governmental and clinical entities. So they all had heard it. They all had heard about the statistics, the obesity statistics I just showed about rates of obesity and overweight in country. They had heard the messaging about healthy nutrition. Many of them had programming in school that had talked about healthy living habits. Again, almost universal awareness. The other thing that was very striking immediately was that there are high rates of what I would call in anthro jargon, self-disciplinary behaviors. And these centered around management of food and management of dress. So a couple of points to make here. The first is that there was a lot of articulated attempts to manage weight by food restriction of certain foods identified as unhealthy, specific management of food and food restriction in anticipation of special events like weddings, and then in the presence of perceived failure to self-manage, then there would be management of dress. So everyone wore an abaya and a shayla, but within that, women would do particular things to hide fat that they regarded as unsightly and unmanageable. And this was really interesting to me because it It resonated very clearly with a lot of self-disciplinary behaviors you see in young people in other countries, but it didn't resonate with older cohorts in country. This was new behavior for a lot of this cohort when I was looking and talking to them about this. So what we see in general were high rates of articulated fat stigma. Women who were higher weight reported getting teased across all different contexts, especially in settings where they had to take their abaya and shayla off. And then there was a lot of expressed concern of the effects of obesity on the country's infrastructure, which is interesting and a sort of a localized expression of fat stigma. And also very interesting, a lot of conflation of tradition with fatness and modernity with thinness. And this was particularly interesting because there was a lot of nostalgia in country around tradition. Lots of interest in preserving heritage and culture and tradition as development was happening. So the conflation of fatness and unmanaged body weight with tradition was not the nostalgic tradition, heritage, and markers of tradition they wanted to preserve. It was sort of this idea of backwardness and not being educated enough and not being forward thinking enough. And it didn't match at all with what was actually going on in terms of, it didn't matter what someone's body weight was. They'd all heard the messaging about the quote unquote obesity problem, but that wasn't the perception. The perception was that people didn't know better. Similarly, there was a little bit of a hook on the modernity thinness. It wasn't all positive. So if someone was too thin, they would often be thought as not spending enough time thinking about tradition and heritage. So they were embracing uncritically this sort of out of control modernity as it was applied to the UAE. So it was a very, there were very thin boundary between what was considered okay, appropriate, and what was not on both sides. So what this added up to was a lot of articulated stress around management of bodies because, as again, making the point about stigma, because the body signaled all sorts of things to peers about what that person supposedly was and was not doing in their worth. And this was really, again, really interesting because it's happened in such a condensed period of time. If you look at the previous generations, not just their mothers and their grandmothers, but even their older siblings, much of this was not part of their experience growing up. This was something that had come in, that had built up in country as a result of public health messaging, social media messaging, media messaging, and so on, and it happened really quickly. Final slide, please. So there are a few summarizing comments I would make here. First, obesity and overweight are obviously still high in the UAE, as the previous stats showed. This includes they are still high among adolescents, as several studies, including some being done during the pandemic, have shown. We continue to see very strong public health programs in country, enviable ones, quite frankly. Interestingly for me, sitting here and not being able to be in country with the pandemic, there's been a rise in body positivity and fat acceptance movements, which I see in particular around social media influencers. But it's not locally rooted in the sense that it's not hearkening back to sort of traditional body ideas of valuing larger framed women. It's very influenced by US and UK body positivity and fat acceptance movements, which have also gained steam in the last couple of years. So it is, I would characterize it as more globally informed than locally rooted at this point in time. Questions I still have, fat stigma and notions of responsibility. It's very hard to parse out from afar what's happening on the ground in terms of notions of who's responsible for one's body management at this point in time and where people are at in terms of their expressed and implicit ideas about stigma. Usually you need a lot of time in country to parse these out because people don't always want to talk about these topics. So this is something that I am very curious what's happening in these 2 to 3 years of the pandemic. Similarly, I'm curious about the effects of the COVID pandemic on the obesity pandemic. Lots of messaging in the US right now about these dual pandemics. I just got off the phone with a former colleague who works in a bariatric program. And she was saying applications for bariatric surgery for things like a gastric bypass are at an all-time high right now because people are worried about being overweight during the COVID pandemic because of all the messaging around that. So that to me is very interesting, especially when you keep in mind something like the fact that bariatric surgeries in the UAE were quite high when I was there. So have they gone up? There's all sorts of interesting questions that remain unanswered at this point that we're going to have to see over the next couple of years what happens. So I'm hopeful that some of you will be doing research in some of these places that will help begin to answer some of these questions. And so that's the conclusion of my talk.
Thank you so much, Dr. Trainer. That was quite informative and insightful, and wonderful pairing with Dr. Hourani's presentation. We do already have a question. I'm going to read it out. It's from Christine Sargent of the University of Colorado in Denver. She says, it's also connected to Dr. Trainer's frameworks. Do parents and children use the term obesity, badana, sumna, etc., or something else? Also, how do parents respond to healthcare provider concerns? How do kids respond, etc.? If you'd like me, Dr. Hourani, to read it again, I'm happy to do so.
No, I read it. Thank you, Rima. Thank you.
Good, of course.
Actually, parents are aware of the problem of their children, not all of them. So they start to consult the dietitians to look for a solution for their children. And usually some schools, they measure weight and height at the beginning of the academic year for children, and they calculate their body mass index, and they tell them if they are overweight or obese. Now, it depends on the parents if they want to apply the advices that they given to their children. Not all of them do that actually, but some who are very caring of their children, they consult dietitians actually to solve that. Yeah. Did I answer the question?
Thank you, Dr. Hourani. Yes, absolutely. Here's a follow-up question. Oh, I think, how are there generational differences, if at all, for how people address or talk about the pandemic of obesity? And it's a question open to both speakers.
So I feel like Dr. Hourani, as I said, one of the obstacles that I am very much aware of right now is that I am not there. So I feel like Dr. Hourani would be more qualified to talk about, because the question was situated in what is happening right now during the effects of the COVID pandemic.
Actually, we need to conduct studies to see the prevalence of overweight and obesity after the pandemic, because they went back to schools. So I was thinking actually of this subject to repeat the study, but just only overweight and prevalence of overweight and obesity, and to see if there are differences between between the previous rates and what we expect what happened during COVID-19 pandemic?
I would speculate based on some of the places that I am currently doing research and then also looking at media and social media, that the longer I spend doing research in this area, the more structuralist I become in terms of put people in a particular environment, and most people, not all people, but most people will behave in the way that that environment sort of promotes. So if you have an obesogenic environment, most people are going to start, regardless of what their weights do, they will start eating differently, and their activity patterns will show that. The pandemic has accelerated that, and more people are sitting more. Exercise is more expensive. Sort of she exercise opportunities, and more difficult because many places close and then reopen or limit attendance. It's more difficult to cheaply just go out and walk and do other forms of daily activity. So there's so many different ways in which it's probably exacerbating people's health. We also know it's having a very profound impact on mental health, which also ties in with this in complicated ways. So with all of that in mind, I again find it so fascinating that one of the things that I have seen is that bariatric surgery rates are going up, because to me that is a very, very small fix for a very tiny percentage of most populations relative to what's actually happening during the pandemic.
Yeah, thank you. I wonder if I could ask you a question myself, Dr. Trainer. This one's addressed to you. You spoke about these enviable public health programs that the government of the United Arab Emirates, I'm not sure which emirate it is, funds. And I'm wondering of the interplay, if you like, between the structural, overlooking the structural address of and laying assignment of responsibility at individual doors. I wonder about the interplay between offering public health programs, which arguably are structural, and laying the responsibility at an individual's feet. Also, I'm so interested in if you've also heard people speak about health or body containment and happiness.
So the first question is, it's an interesting one. When I say enviable, I mean that I have many colleagues who work in places which are characterized by insufficient healthcare coverage. Some of the main issues are that people can't get in to see a doctor. They can't get life-saving medications. Limited resources all around. And I have worked both in the UAE and then in subsequent projects in some places that had fantastic healthcare coverage. You could get in, you could get medications, you could see a clinician when you needed one, you could see multiple clinicians. So in that case, these are places and programs where they can give good coverage, and they're trying very hard to give patient-centered care. Of course, there are, as a social scientist, there are always interesting qualifying comments you can make about those, because they are all operating from a biomedical model. So they are all using some of the same rubrics to measure health, and that includes looking at obesity and overweight in very simplistic ways in some cases, especially in adults. I think Dr. Al-Harani's presentation on children showed that there are some more nuances going on with some of the research in kids, but in adults, the nuances slip off. So not always looking at health holistically and more often just looking at weight numbers. There's also some interesting discrepancies in terms of how clinicians every day interpret what they're supposed to be saying to patients about weight, because many places are compelled by national or international standards that if someone is registering certain, if their height and weight come back and they're obese, you are, as a clinician in many contexts, compelled to mention it. Many clinicians don't want to mention it because their experience is people don't react well. So there's some tension in terms of the everyday interactions around that. In terms of happiness, I think I didn't totally understand the question. I'm wondering if you would expand on that a little bit.
Oh, and I realize, your work is as a medical anthropologist and you're working with a lot of biomarkers, but I was just interested if you'd heard observations. My own anecdotal impressions have been that I hear a lot about if you're healthy, if you have more self-discipline, it leads to a longer, happier life. So a lot of it, like the reward comes in terms of happiness. So I'm just wondering if that's something that you've encountered with people with whom you're an interlocutor or beneficiaries of programs. That's the intention of the question.
I see. I think that's a really interesting question, because I think that idea that self-discipline leads to happiness, and that the self-discipline is, there's all sorts of different self-disciplines of the body one can practice. I mean, most obviously, you see all sorts of, most world religions have certain self-disciplinary practices that are based around bodily practice. But the emphasis when you're talking about self-discipline in the case of management of the body around food intake and weight and health maintenance in a larger context where every single signal is yelling, consume, consume, consume. That is interesting because it's recent. And so I've seen a couple different streams there. One, I've seen a move away, including in some medical programs, to not talking about discipline, but talking about mindfulness. I find that interesting. It's not quite the same thing. And so I think that's a really interesting development. I'm still sort of watching what happens with that. It seems to resonate with some people in terms of helping them think about mindful living, not about weight management. But the self-discipline is difficult because for the most part, self-discipline, again, in an environment that can cues lack of discipline is failure. And so most often it doesn't lead to happiness for most people.
Thank you for that. Thank you for that clarification, Dr. Trainer. Dr. Hourani, a question for you, please. One of your earlier charts, I believe, had mentioned something about diabetes 2, type 2, and race and ethnicity as determinants. So I wonder if you could speak some more about that, especially on, if possible, the multi-country levels. You gave us data for a number of countries. So I'm very interested in how obesity, overweight, and type 2 diabetes manifest themselves, thinking about race and ethnicity.
Actually, it's not the weight, and it's the risk of diabetes and ethnicity. First of all, the child should be obese or overweight. Then we have the risk factors. We have 4 risk factors. One of them is the race of ethnicity. So some races and ethnicities, diabetes runs there and those ethnic groups. So it makes an extra risk factor for those people, in addition to family history or signs of insulin resistance.
I'm wondering, to follow up on that, are there any, if at all, sociocultural determinants? Why is it that there is a predominance amongst certain ethnicities? What do the data tell you? What does the science say?
Actually, I didn't go to something like that. Yeah, when I picked the risk factors, actually, it was the family history, some signs of insulin resistance, and if the mother has gestational diabetes or she's already diabetic.
Thank you, Dr. Han. Thank you. I think what we're going to say is, we're going to say this is the public portion of this session has ended. We're going to thank all members of the general public who have joined us. We're very happy that you have. And if you're a student, please stick around. Thank you so much, everyone, for joining us. An important note that our Associate Director, Muzammil Hussain, who usually humans this series, had a personal emergency, which is why he cannot and could not be with us. But it's my pleasure and my honor to be here with all of you. Thank you so much to the general public for attending. We look forward to your attendance next week. It'll be our last session